To the Snyder Institute for Chronic Diseases Mini Medical School Lecture Series. We are pleased to host a compelling presentation and discussion this evening on the topic of After 100 Years of Insulin, what have we learned about the cause and treatment of diabetes and pancreatic adaptation to pregnancy and overnutrition? My name is Hannah Riley, and I will be the program host for this evening. Before we get started, I would like to go over a few housekeeping items. There'll be two parts to tonight's program. First, each of our presenters will speak for about 20 minutes, and then we'll open the floor to audience questions. We'll take a 10-minute coffee break between each speaker, and refreshments will be provided to those of you here in person. You're welcome to ask your questions at any time during the presentations using Slido. To access Slido, you can scan the QR code or type www.slido.com into your browser and manually enter the event code MMS into the participant field. Questions submitted to Slido will be viewable to all audience members, and participants can upvote the questions they would most like to see asked. Now on to more specific housekeeping items. For those of you who have joined us online, if you lose your internet connection and drop out, you can return to this session using the same Zoom link that you used to join us at the start. If you experience any technical issues, such as you cannot hear or see the presenters, please email snyder@buxa.com and our team will do their best to support you. For those of you here in person, we ask that you now switch your cell phone to silent mode. Please note this event will be audio recorded and the recording will be posted on our Snyder Institute website. Now, to begin our program, the Snyder Institute at the University of Calgary's Cumming School of Medicine, located in the heart of southern Alberta, would like to acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. And now, I'm pleased to introduce our first speaker of the evening, Dr. Carol Huang, who is the head of the Division of Endocrinology at Alberta Children's Hospital and an associate professor in the Departments of Pediatrics and Biochemistry and Molecular Biology at the University of Calgary's Cumming School of Medicine. She's the full member of the Alberta Children's Hospital Research Institute and an associate member of the Snyder Institute. Dr. Huang's research program focuses on molecular mechanisms that regulate pancreatic beta cell function under conditions of metabolic stress and how the microbiome and metabolic stress links to the progression of type 1 diabetes in children. Please join me in welcoming Dr. Huang.
All right. After a very long title, I'll reduce my title to one word, diabetes. I have nothing to disclose. So just briefly, we'll just talk about, start by how does our body actually use food and what are the different types of diabetes that's out there. And I'm going to, because I'm a pediatric endocrinologist and 99.9% of my time spent on type 1 diabetes, that's how I will be talking about. And Dr. Bassyouni will be talking about type 2 diabetes. So have you ever thought about when you eat, what happens? So the food that you eat, and for the purpose of this, we'll talk about carbs, juice, your donut, your pizza, whatever. Your body, once you ingest it, your body breaks it down into glucose or sugar. It enters the blood. It travels to this little, what happened there? Oh, there we go. So it travels to the pancreas. And in the pancreas, which sits right behind your stomach, it has these little organelles called the pancreatic islets. In these islets, they are the cell called beta cells. And beta cells are the cells that make the wonderful hormone called insulin, which then go to your blood, travel to what we call the target tissue. So maybe you never thought of this before, but the sugar that you ate actually goes to three main target tissue. One is your muscle and your fat and to your liver. The insulin will bind to the insulin receptor on each of the target tissue. And it will activate the glucose transporters on muscle. It's called GLUT4, allow the sugar to enter into the muscle cells. And with that, the muscle can metabolize that sugar and generate energy. Any extra sugar your body doesn't need to generate energy for the time, it will make it into glycogen. So I don't know if any of you runs marathon, but you heard of people say they have to carb load before they run a marathon. So that's what you're doing. Your body's making the extra sugar into glycogen, storing your muscles. And when you are running that marathon, your body can release that, break down that glycogen and release the glucose, and you can go run for 4 hours or whatever. And then in the fat, it does similar thing. It binds to insulin receptor, and any extra is stored as fat. And again, it also has glucose transport, allow the sugar to come in. In the liver, it does two different things. Normally, if you're not eating, the reason your blood sugar is not going low is because your liver will release sugar. So you don't go what we call hypoglycemic. But when just after you eat, you have all this sugar floating around, and in response to insulin, the glucose will enter the liver, and again, it's stored as glycogen. So this is what happens when your body functions normally in response to eating a carbohydrate. So when you have diabetes, something is broken. Either your body doesn't make insulin or your tissues does not respond to insulin. So simply put, what's diabetes? When your blood sugar is too high. Normally, our blood sugar is between 4 and 7 millimolar per liter. And either you can't produce insulin or you can't use insulin, you have diabetes. Now, if you go to a medical textbook, this list would be a mile long. But for today's purpose, we will talk about type 1 diabetes, type 2 diabetes, and gestational diabetes, which means that diabetes first diagnosed during pregnancy. And for all intensive purposes, that's really a form of type 2 diabetes. And you will also hear people have other types of diabetes, what we call MODY or monogenic diabetes. So if you don't have a particular gene that allow your body to make the beta cell that makes insulin, you can have diabetes because you're missing the gene. Or you have something called cystic fibrosis. Now that's a condition where your sodium or your salt channels doesn't work, mainly in your lung and your other parts of your pancreas. But if you have cystic fibrosis, you are also prone to having diabetes. And for drug-induced diabetes, for any of you who have ever taken steroids for any reason, for your inflammatory disease, and in our world, we see a lot of kids who's on chemotherapy, who has steroids as part of their chemotherapy. The steroids actually can cause diabetes, and it does it mainly by acting on the liver and keep telling the liver to keep making a lot of sugar. So this is Diabetes Canada kind of medical definition of type 2 diabetes. And so basic type 1 diabetes is, think of it as your beta cells is being destroyed by your body. And the most common cause is the autoimmune process. Does everybody know what autoimmune disease is? So, I think after COVID, everybody learned about our immune system. So in autoimmune disease, for some bizarre reason, your body thinks the beta cell is not your own. So your immune system decides to attack the beta cells and destroy them. And as a result, you can make insulin. So these people have absolute insulin deficiency. Without insulin, they cannot survive, period. Type 2 diabetes is actually, over the years, we discovered it's a big family of disease. When I was in medical school 30 years ago, we were told it's all insulin resistance because your muscle and fat and liver doesn't respond to insulin. But now we actually learn for some people, they are, in addition to insulin resistance, for some reason, even though they have the beta cell cannot secrete insulin properly for whatever reason. So there is a range of people with, some people are predominantly insulin resistant. Their body makes tons and tons of insulin. They just don't know how to respond to it. Or some other people, they are not insulin resistant. respond to glucose for their beta cell, even though it's there, it just doesn't know how to secrete insulin properly. So type 1 diabetes. So this slide's a little old, but I think it shows you what I want to illustrate is, so the darker color, so Scandinavians, British Isle, Iceland, Saudi Arabia, and unfortunately Canada, we have some of the highest incidence of type 1 diabetes per 100,000 people. And it's most commonly diagnosed in children. So the typical kid will come through, they are, school age children, and they peak around age 12 to 14. And in contrast to other autoimmune disease, which are usually much more common in women than men, there's actually no such difference. Girls and boys are equally, susceptible to get type 1 diabetes. And interestingly, in adulthood, men actually get a little bit more frequent than women. And why do you get type 1 diabetes? We know a lot, but we also don't know. So if you look at the y-axis, you can see, you're born with kind of 100% of the beta cell. Again, beta cell is the cells that makes insulin. So you need to have some kind of genetic predisposition. If you don't have those, it's very unlikely you will get diabetes. But also there's some environmental factor, because if you have identical twins, only 40% identical twins will both get type 1 diabetes. So obviously the environment plays a role. So we think of diabetes as having 3 stages. Stage 3, basically you'll have type 1 diabetes. You have symptoms, your blood sugar is abnormal, and you basically have only about 20% of your beta cell left. But then even in stage 1, this autoimmune destruction of beta cell started already. So over time, you start losing the beta cell, but there's no dysglycemia. Dysglycemia means abnormal blood sugar. So your blood sugar is still normal. And when you continue to lose the beta cell because your immune system keep, destroying your beta cell, you will start having high blood sugar, but it's not high enough for you to have symptoms. So, and that will persist for a while until finally stage 3, you have diabetes. And I talk about this autoimmune disease, and then you also have autoimmune antibodies. So AB stands for antibody. So antibody is a marker that we use to predict who will get type 1 diabetes. And I was just saying, if you have none of them, your chance of getting diabetes is very low. So the y-axis here is the proportion of people without type 1 diabetes. So the flat line means you never get diabetes. So with increasing number of antibody, you're more and more likely to get diabetes. And basically, if anybody has more than 2 antibody, we basically tell them your lifetime chance of getting diabetes is essentially 100%. So what are the signs or symptoms? So some people talk about the 4 T's, some people talk about the 3 P's, but basically you go to the toilet, means you're peeing a lot, because glucose is what we call osmotic diuresis. Glucose pulls water into your kidney and you pee that out. And because you're peeing all day, then you become very thirsty. So it's the peeing that drives the thirst. And they're also very tired, because remember I told you in the beginning, you eat all these carbs, and carbs are probably 50 to 60% of our diet in terms of calories. And then your body's not able to use that. So think of, if you're peeing out half of your calorie, you're going to be very tired. And then also you will lose weight. So in kids, what do I see? Unfortunately, we're seeing more and more very young children showing up with diabetes. So it's not uncommon for me to see a 15-month toddler show up in the emergency room with very poor appetite. They are throwing up, they are dehydrated, and they are breathing very fast. And actually have seen some of these kids got sent home with Ventolin because of diagnosis of asthma, because nobody thought of them as having diabetes. You just don't associate diabetes with a little baby. And more commonly, it will be a 6-year-old show up emerge. Again, they are totally dry before, but now they have secondary nocturnal enuresis, meaning they start wetting their bed again after being dry for 3 or 4 years, because they are peeing so much because the glucose that's in their blood is pulling out all the water and they just can't go to the bathroom fast enough. And, some of these kids will complain, they go to the bathroom on an hourly basis at night. And another one, commonly a 12-year-old, we see a lot of those. So they call it polyuria, meaning poly means a lot of peeing, polydipsia, a lot of drinking, and they have weight loss. And we see a lot of them in September. And I think a lot of people just don't realize in summer, but, kids are drinking and peeing, the parents just say, oh, it's hot. So they're drinking a lot. So they don't kind of think about it. They don't realize that's actually the symptom. So if any of you have kids or grandchildren, who's kind of drinking and peeing a lot more than you expected, think about it. How do you diagnose it? Blood sugar. If the random blood sugar is greater than 11.1, remember I told you our normal blood sugar is between 4 and 7. So if, and if you're drinking and peeing a lot, random blood sugar is 11.1, they probably have diabetes. And if I know some of you, who had an oral glucose tolerance test, OGTT, where they give you that really yucky orange drink to drink and then measure your blood sugar 2 hours later. If that is more than 11.1, you can have type 1 diabetes. Or if your fasting blood sugar, meaning that you haven't eaten for 8 hours, is greater than 7, you have diabetes. Ideally, in type 1 diabetes, we'll check for antibody. Remember, I told you this is an autoimmune disease, right? So if you're autoimmune disease, you want to make sure you have the antibody. And we do have parents ask me, prove it to me, my child has type 1 diabetes. So we do check for autoantibody, but usually the kid's presentation is so typical, and this autoantibody takes 2 or 3 weeks to come back, and it costs a few $100s to do. So we don't normally do them as part of our routine, but we can check for the antibody. So initial management. Most kids, I would say 60% of the kids, they can just walk into our emerge and say, yes, I'm peeing, drinking a lot, otherwise reasonably well. But some of them are sick enough to be admitted. About 40% of them, as about 5 to 10% actually be sick enough to be admitted to ICU. And after the first couple of days, once they are, they are rehydrated, they feel better. The main thing is start education. So education is diet, talk about how to eat, insulin, how to measure your blood sugar, and how to make this part of the daily routine. Because basically they have to check their blood sugar 4 times a day, give insulin 4 times a day, they can order food for everything they ever eat, and their exercise. So it's a life-changing diagnosis for these kids and for this family. And diet, sometimes I hate to use diet because it's not a diet like, I don't know, whatever. It's really think about food. And so we follow the Canada Food Guide, and then we encourage basically healthy living. And I always tell the parents, there's not a special set of diet for these kids. Everybody in the house eat the same way because everybody in the house eat healthy. Yes, these kids go to the birthday party. Yes, they can have cakes, whatever, but no one should be having cakes every day. Right? So, and then most of our teaching is about carbohydrate. Because remember, for all intensive purpose, protein and fat doesn't really affect your blood sugar. It's the carbohydrates. So we teach people, we spend a lot of time reading labels. So you know how much insulin to take if you know how much carbohydrate you're going to eat. Before we move on, I just want to talk about discovering insulin. So I think most of you, I hope you have heard, 102 years ago, in 1921, something that changed the life of type 1 diabetes. Because until then, basically, type 1 diabetes was a death sentence. Everybody with diabetes, type 1 diabetes died within weeks or months after because there's no treatment. But before that, there's at least over 400 publications and researchers, and there's a lot of people over the time who culminate to that work. So I'll just highlight a couple. So Dr. Paul Langerhans, in 1869, he discovered the pancreatic islets. Remember, there's a little structure in the pancreas that secrete insulin. So they are named Islet of Langerhans in honor of him. And Dr. Minkowski in 1889, he first discovered if you remove the pancreas from the dog become diabetic. So now they know, okay, there's something from the pancreas stopping the dog from being diabetic. And then further, Dr. Ziller and Dr. Pelescu have discovered that if you get the extract from the pancreas, if you give it to the dog, he's able to lower their blood sugar. But unfortunately, they are not pure enough to actually be able to do that in human. So basically, you know, all those years, people have known there's something in the pancreas that can lower your blood sugar, but they can never get it in a pure or clean enough of form so that you don't get sick from this injection. Because when they get injected, they actually get septic shock because they're basically injecting with something that's dirty. So any of you like to read, I highly recommend this book. I don't know if you can see that, it's a little dark, but it's called The Discovery of Insulin. It's a fascinating read. A story. This is the fastest story from discovery to Nobel Prize. No one has ever discovered something and been given Nobel Prize within 2 years, ever. And reason being that, you know, like I say, before that, type 1 diabetes is a death sentence. With this, these people actually get to live. Banting was a family doctor. He was actually not a very successful doctor. He actually couldn't make a living as a doctor. That's why he went to Dr. McLeod's lab to work as a research assistant. Charles Best is a graduate student that Dr. McLeod gave to Dr. Banting during that summer of 1921 to help him with his experiments. And Dr. Collip is actually a biochemist from University of Alberta who helped them purify the insulin to a form, because they were actually injecting people with 10 cc of insulin into their buttocks. Can you imagine? That will hurt like no, you could not believe. And actually, I think the first person actually got 2 doses, 20 mils. Oh, anyways, but they actually managed to concentrate it to clean enough so they don't cause them to get sick, and it works. As again, so there's a lot of politics behind who gets Nobel Prize. It was given to Banting and McLeod, but they didn't think it was fair, so Banting decided to share with the Best, and McLeod decided to share with the Collip. Read the book; it's fascinating. Leonard Thompson, 14-year-old boy. He was only 27 kilograms. He's the first. That's like 50 pounds. He's the first person to receive insulin, and he continued to live for another 13 years. Unfortunately, he died not from diabetes, but from pneumonia. Daily managerial diabetes. So now come back to type 1 diabetes just quickly. So, you know, they have to check their blood sugar. Either with a lot of you probably have seen a meter, but then most of our children now have chosen to use what we call continuous glucose monitor, either Dexcom or Freestyle Libre. That's what's available in Canada. And they will give insulin either by the syringe or by an insulin pump. School-age kids, because they don't know how to give insulin by themselves, they are usually give the insulin 3 times a day. So at breakfast, supper, the parents will give them a dose of insulin, which get rid of food. And they also the parents will give some basal insulin at breakfast, again at bedtime, kind of cover the rest of the time. Because even when we are not eating, our body is always making a little bit of insulin. For any kids that's junior high school or up, we'll expect they should know how to give insulin by themselves. They are usually giving what we call basal bolus. So again, they give a 24-hour long-acting insulin, and every time they decide to eat a big meal, they will give some insulin. So even though we say 4 times, some kids, especially those big teenage boys, they can give 6 or 7 doses of insulin a day because they rather eat and get insulin than starve and not get insulin. And pump, they work on the same basic principle as the basal bolus. The only difference is that you can change the basal rate, which is great, for kids who's athletics. For example, if you're going to play hockey, so because you're using a lot of sugar to play hockey, you expect your blood sugar to go down. You can just lower what your basal rate of insulin, then you won't have low blood sugar. And also right now there's what we call sensor augmented. So you have, remember those, continuous glucose monitor, it will talk to your insulin pump. So if it sense that your blood sugar is going up, it will tell your pump to give a bit more insulin. If it sense your blood sugar is going down, it will tell your pump to hold the insulin. So it's not quite artificial pancreas yet, but we're getting there. And lastly, kind of routine, follow-up. We see them every 3 months. They come to clinic. We check their something called hemoglobin A1C every 3 months, to see how their overall, blood sugar is. And we screen them for things like thyroid disease and celiac disease, because these are two relatively common autoimmune disease these kids also get. And we also screen them for, complications such as neuropathy, which is nerve problems, nephropathy, which is kidney problems, and retinopathy, which is eye disease. And lucky for us, we usually don't find them in kids. Very quickly, I can spend hours talking about this. I chose 3. One is something that hopefully will come soon, is dual hormone pump. So right now, the insulin pump, it gives insulin. But how we give insulin is an educated guess. We think, okay, you're going to eat this much, you have exercised this much, I think you need this insulin. So it's not uncommon for we to overshoot and people have hypoglycemia or low blood sugar. And as well, during exercise, depends on how intense exercise, they can drop the blood sugar. So here's an example where the pump will give 2 hormones. One's obviously is insulin. The other one's, glucagon, which actually raise your blood sugar. So you can see in this pump, the purple is when you have 2 hormones and pink is have only the insulin. So this drop in blood sugar is not as serious when you're giving 2 hormones versus only insulin. So the idea of this is that to prevent people from having hypoglycemia, because the fear of having hypoglycemia has actually been a big barrier for a lot of people on how to manage their diabetes better. Here's another Alberta story. Islet transplant. So remember islet are those little organelles in pancreas that makes insulin. So, if I take the islet from a human who doesn't have diabetes and give it to someone who has diabetes, theoretically can cure them. People have tried this since the 1970s, but they have never been able to successfully do this for more than 2 or 3 days because the recipient's body always rejects it. But in July 2000, University of Alberta, the first report, 7 patients, they become insulin independent for an entire year. Prior to that, they've been insulin dependent for maybe, 3 weeks. But this is the entire year, and it's successful. They continue to have this program, but the problem with this should be quite obvious is we isolate the islet from people who have died from most likely, car accidents and things like that. So the source islet is limited. So basically, the donor, you take out their pancreas, you isolate the islet, and you actually inject them into the liver. So the patient, type 1 diabetes patient, actually come to clinic, they have to have this, go to radiology, got this inject in the liver, and then walk out of there. So it's not some big surgery. So it's quite remarkable. But they only do it in people who has really severe diabetes because, the obvious thing that comes with this is you need to take, because you are injecting a foreign islet from a different person. So you have to take anti-rejection drugs, and anti-rejection drugs themselves can be quite toxic. And we also have to talk about stem cells. So, with the islet transplant, obviously, like I said before, there's a limited source islet. But if you have stem cells, then the source is unlimited. The problems is that we have yet been able to make the stem cells into beta cells that secrete enough insulin to make a clinical difference. But we are able to make cells that makes insulin. So here it's actually a device. Again, this is a study that's done at UBC as well at the U of A. So they have this device where they put the islet in the middle that allow the oxygen to go in, but all the immune cells that's going to attack you and destroy the islet cannot go in. Okay, so they can, but they also allow the insulin to come out. And you can see this picture. So pre-transplant. So this is kind of what they transplant in this device. There's all this blue stuff. And then the red is insulin. And the green is the cell that makes glucagon, the hormone that allow you to increase your blood sugar. And after they transplant it in there and over a few weeks, it's almost like they will grow and multiply. So you can see they make, you start having insulin, a lot more insulin positive cells. But you notice there's a lot more glucagon positive cells than insulin positive cells. So we have to get it right. So we actually make more insulin positive cells instead of the glucagon positive cells. So that was the end of science. So, we do in type 1 diabetes, and, is a life-changing diagnosis. But we do tell our kids that you can do anything you want. We run a diabetes camp at Camp Kindle. So for 4 weeks a year, the camp that has, they have doctors and nurses. So kids can go there and kind of be normal kids, because most of the parents, as you can imagine, they will be very afraid of let their kids leave them overnight. Because how would the other parent or somebody else, sleepover is a big deal for these kids. How will anybody know how to measure their sugar? What happens if the insulin pump didn't work and they can give insulin? So that's something we run. And then, I didn't know this. I had to Google. So I don't know if you recognize all these people. I think you probably recognize some of these people. So I put their names below, but there's actually a lot of famous people with type 1 diabetes. And that is it.
Thanks, Dr. Huang. That was a great presentation. We'll now take a 10-minute coffee break. So enjoy if you're here. There's coffee and muffins outside the doors. Otherwise, we'll be back in 10 minutes. And I hope you all had a chance to grab a snack and a drink. I'd now like to introduce our second speaker of the evening, Dr. Hanan Bassyouni, who is a practicing endocrinologist and a clinical associate professor at the University of Calgary's Cumming School of Medicine. In addition to her clinical and academic work, Dr. Bassyouni provides outreach endocrinology consultant services to several clinics serving underprivileged and marginalized populations. Welcome, Dr. Bassyouni.
Thank you so much, Hannah, for this nice introduction. Good evening, everybody. It's really nice to see all of you. Can you hear me okay in the back? Yeah? Okay, awesome. So, I know it has Carol's name. I was being polite and putting everybody's name on the slide. So, welcome and thank you for being here tonight. I thought I'll start with just telling you a little bit about myself, because I think everybody gets nervous when they see me and think, which country did she come from? And does she know what she's talking about? And can she speak English? So I just, put your minds to ease and just tell you that I do speak English. So I'm Calgarian all the way. I was born at the Foothills Hospital. My parents were here. Everybody has ever leave. My parents actually were in North America studying. My mom was studying in Michigan towards her PhD in home economics, and my dad was getting his PhD here in University of Calgary in management and things like that, although he's an aviation engineer by trade. So when I was 3 years old, I went back to Egypt and I grew up there and then came back here in grade 12. So I went to Diefenbaker. Anybody familiar with Diefenbaker? Yeah. So that was my high school. That's where I went to grade 12. And then I went to UFC to do my undergrad in biochemistry. I don't know why it's cutting out like that. Yeah. Maybe it's a spot. There's a bad spot in this section here. I know that because I teach here quite a bit. So, and then I went to med school here in Calgary. So I'm a UFC grad. I'm class of 98. And at University of Calgary, every class has an animal, and my animal is a skink. That is a lizard, and its head looks like its bum. And then I did all my training here. So I did internal medicine residency here in Calgary, and I was chief resident in 2000. And then I did my fellowship in endocrinology here in Calgary. And I stayed here since then. I've been in practice since 2004. So I'm very much Calgarian, except for the 12 years of that I was in Egypt. But thank you. So anyhow, so you can now relax. I do speak English. I know what I'm doing, hopefully. I have the task of talking about type 2 diabetes today. And I wanted to start off with disclosures. I am really boring. I don't have anything important to declare here. I wanted to just thank Dr. Huang for actually allowing me this opportunity. She is the one who invited me to come and co-speak with her. So thank you so much, Carol, for inviting me to come tonight. I also wanted to thank Dr. Butalia and Dr. McKean because they're two of my adult endocrine colleagues who, some of those slides are from, guideline presentations that they have done for our division. I'm not sure why my mic is doing that. Is there anything I can do to kind of, should I just use a handheld one or? Okay, we'll try that. So, diabetes is the star of the show today, even though there's nothing about having diabetes that makes you feel like a star, I must say. I am going to focus on type 2 diabetes, and I just wanted to let you know that I teach at the medical school quite a bit. I chaired the endocrine course for 11 years and the communications course for 10 years. So I don't believe in didactic one-way dump of information. So I just wanted you to get the heads up that I'm going to be asking questions. I will keep track and I will give you marks at the end. No, I will not. I will definitely not be doing that, but I do like to have some interaction. So I hope that's okay with everybody who's here today. I notice the crowd is not very young, which means you're not intimidated to answer questions, hopefully. But I'm not going to pick on you. Don't worry. So, when I have audience participation, that means I'm going to ask you a question. Okay. So what does diabetes mellitus mean and where did this term come from? Does anybody know? I see no's. Anybody? No? Okay, but your brains are thinking about it now, so that's good. So actually, as old as India in 1500 BC is when people started to notice that some people were peeing so much. And that's when people were thinking, there must be something different about that. Why are people peeing so much? And also the ants and the insects were sticking to the pee. Don't ask me why people were looking at ants and insects sticking onto pee, but that was probably because of the sugar that was in there. So the urine was sticky. And so it was attracting, because it was sweet, it was attracting these bugs. It wasn't until 250 BC, actually, that the term diabetes mellitus came about. And that was in Egypt. This is a complete coincidence. I grew up in Egypt. My DNA is Egyptian, but this is a complete coincidence. So the term diabetes was actually coined in Egypt, to mean going through or siphoning. That's what kind of, diabetes means. And then mellitus means honey. And so that's where it came from, that there was sweetness to that urine, that people were siphoning through all this urine and peeing so much. So a long time ago, and around these days when people didn't know much about what diabetes was, they noticed that there were some things that they could do to make this better. So they used things like horseback riding. I have no idea how that helped. Honestly, no idea. Bloodletting. Again, I am not sure how bloodletting helped. Maybe they let out some of the acid of the blood, but that would also get rid of the blood. So I'm not sure if that helped. I'm sure these people did not survive when they had all this bloodletting and cupping. And then opium was also kind of described as some treatment, but I don't think it really did wonders for those people. Maybe it just knocked them out for a bit. I don't know. And then starving them. So that was a classic thing, that people would starve patients who were suspected to have this weird condition of diabetes. Probably because taking more sugar would make you pee more, which would make you more dehydrated and more thirsty. So starving people would help with the symptoms temporarily, of course. Ultimately, what they needed was insulin, and that's what killed them, was when they did not have insulin. So it's just interesting to go through the history of things and see how things evolved. So when we think about type 2 diabetes, we think about always non-pharmacologic treatment and then pharmacologic. So nobody comes to see me about type 2 diabetes and I'll be like, well, you have to go on this medicine right away. That's not the first line, right? So the first line is always going to be to talk about lifestyle and diet and things that we can do every day to help us be better, be healthy. And then in turn, after that, we pull out our toolbox and say, okay, well, if this first line is not working and doing what we needed to do, then should we go to other medications? Okay. And the medications, we used to have very few, and now we have a lot of choices to go through with our patients, which is good. But can be confusing for people at times as well. So you'll notice that nutrition, weight management, and physical activity will never die. We will never say to you, you can stop doing that now. We'll say, keep doing that. Keep doing that. And then on top of that, we can use some of what we call anti-hyperglycemic agents. So that means anti means against high sugar agents. And there's oral agents, and then there is injections, and then there's insulin. Okay, so those are kind of the big categories of treatments. Diet and lifestyle, agents that we can give by pills or injection, and then insulin. So if we look at the history of diabetes meds, as Carol already alluded to, insulin was discovered in 1921. And then after that, the next drug that came for type 2 diabetes was sulfonylureas. These are medications that stimulate the pancreas to make insulin. So it's actually like beating the pancreas and saying, make more insulin, make more insulin, make more insulin. So this was probably the first oral drug that was discovered. And then after that came metformin. Metformin works a little bit differently. It actually sensitizes your body to the insulin that you already make. Okay. So sulfonylureas makes your body produce more insulin, whereas metformin makes your insulin work better. And that was in the 1960s. In the 1980s, another class came out known as, I don't know if you heard of acarbose, but this is a glucosidase inhibitor. So this is an agent that slows down the absorption of sugar in your gut. And that kind of works well for a pancreas that's not working very well. It makes your sugar peak slowly. So therefore your sick pancreas can cope with a small peak, but it can't cope with a big peak of sugar. And then in the 1990s, this class of agents called thiazolidinediones. I know it's a mouthful. Nobody could pronounce it at all when I was in med school. I remember that class was just coming out when I was finishing my med school. And those agents were like the new big hype. Everybody was so excited about them until studies showed that actually they increased deaths from cardiac events. So all of a sudden, everybody's like, we're not doing that anymore. They're still on the market, believe it or not. And so they are used very selectively for certain conditions, very specialized conditions. But typically, you should not be on these medications if you have type 2 diabetes. So remember that. TZDs, no, don't want those. They can also worsen heart failure and things like that and cause fluid retention and weight gain. So that was in the 1990s. So when I graduated medical school, this is what we had. We had, of course, insulin. We had metformin and sulfonylureas and this acarbose. And then we had the TZDs just coming out and then exiting very shortly thereafter because of those concerns of heart safety. Then we had a very short-acting form of the sulfonylureas called meglitinides. So those are like really quick in and out medications. So they're safer in a sense, because sulfonylureas can last in your body for a long time and cause hypoglycemia. Your body just doesn't metabolize them very quickly. Whereas meglitinides are very similar, but they're in and out, fast in and out, so safer. But you have to take them several times a day. And then came incretin-based therapy or incretin-based therapy, however way you want to pronounce it. And that was a huge breakthrough. So this was a game changer kind of finding. And you might have heard of Ozempic. Who here has heard of Ozempic? Who here has not heard of Ozempic? Not heard of Ozempic. Wow. This is great. There is somebody who has not heard of Ozempic. So incretin or incretin-based therapy is something that has transformed how we think about diabetes. And I'll talk about that a little bit more. And then really the newest kid on the block is the SGLT2 inhibitors. Those are the ones that act in the kidney and they make you pee out more sugar to get rid of that sugar. But they also can, of course, provoke then dehydration and other problems. But they are also, in the world of kidneys, a big game changer because they preserve kidney function. So you can see that, our ability to treat diabetes has expanded significantly in the last decade or so. So how big of a problem do you think type 2 is? Because Dr. Huang was talking about how type 1 diabetes, we have a very high incidence and prevalence in Canada, but worldwide, it's a very small minority. When you look at all of diabetes in the world, it's a small minority of, the percentage wise. So what percentage of people do you think are living with type 2 diabetes or pre-diabetes? Yes, Maya. You say 90%? Wow, that's a pretty pessimistic approach, but thank you, Maya. It's actually not that high. It's about 9% for type 2 diabetes, but higher for prediabetes. We'll come to that. But this was a reasonable guess based on, how being overweight is something that is increasing and obesity is increasing. So if you look at this is a very interesting graph that plots out countries from Europe and the West. And if you look at the highest prevalence of diabetes, type 2 diabetes, it's in the United States at about 10 point something %. And then Portugal is next, and then Canada is third. And I think that's really disappointing to see that. It's really disappointing to see that Canada is third when it comes to prevalence of type 2 diabetes. And then the lowest is actually the United Kingdom. And I'm not sure why that is. Maybe they just walk everywhere. Their cities are laid out in ways in Scandinavia and in Europe that people walk and bike. Instead of here in Canada, we always drive everywhere. So it probably has to do with big picture kind of things. So further to what Maya mentioned about the 90%, I mean, it wasn't a bad thought at all, Maya. So even though diabetes prevalence is about 9.3% in 2015, it's probably much higher now. Diabetes is about 22%. Okay. And we saw a huge increase in this decade from 2015 to 2025 is expected to be 44% based on calculations from previous decades. So this is definitely a pandemic, whatever you call it, endemic, whatever you want to call it. So in Alberta, 1 in 4 people have prediabetes or obesity, so 25%. So while 90% is a bit of an overestimate, I worry that we could be moving our way there if we don't make some changes. So when do you think your risk of developing type 2 diabetes, when do you think that risk kind of goes up? Do you have any guesses? Because when you're younger, even if people have, say, a family history of type 2 or your parents have type 2, your chances are smaller when you're younger. But as you get older, that risk goes up. So when do you think that inflection point happens where, your risk kind of rises? 50s? That's a very good guess. Yeah. Any other thoughts? 60s? Okay. Yeah. So it's actually after 40. So after 40, you really start, you know how life falls apart after 40? That's what I heard. And I guess it's true. So you will see here that, like Dr. Huang was saying, males have a slightly higher predisposition for diabetes in type 2 diabetes, just like Dr. Huang was talking about even in type 1 older. But in younger years, like in the pediatric world, girls and boys are equal for type 1. In the adult world, guys are more likely to be impacted, males than females. And if you look with every decade of life, you can see how it's rising really significantly. And that's why your habits really matter. So if you build some good habits when you're younger, you hopefully prevent the chance of developing all these problems later on. But you see the peak is around 70s and so on, but it certainly takes off quickly, here. So type 2 diabetes can be thought of as a progressive condition, right? So you have a progressive loss of beta cells. So maybe at the age of 40, you don't have great beta cell function, but you have enough to keep you going. But over time, as we age, we actually lose beta cell capacity. It's kind of sad. We kind of lose a little bit of our beta cells. How fast we lose our beta cells depends on our habits and our lifestyle and our weight, but it also depends on our genetics. So some people have a disadvantage genetically, and some people have an advantage. Some people have protective genes. And the reason I say that is because if you think of let's say two people who are really overweight. So let's say two people who are morbidly obese. You would think just by looking at them, they're definitely going to have type 2 diabetes. But one of them might have it and one does not have it. Why does the one who still weighs the same weight not have it? Maybe they have some protective genes. Maybe there's something about their DNA that is different. So the story is not just in one thing or the other. So as Dr. Huang was talking about, there's insulin deficiency. So there's beta cell dysfunction, and then there's insulin resistance as well. So insulin resistance, you can spot in a person. If anybody has a bigger belly, no offense to anybody who's here has a bigger belly. If you have a bigger belly, you know right away this person has more insulin resistance. But that does not mean they're going to develop type 2 diabetes. Are they at higher risk of developing it? Yes. But it's not a must. They don't have to do it. You still can have other protective genes or other things going on. So to develop type 2 diabetes, as Dr. Huang was saying, we used to think it had to be just insulin resistance. But the truth is You can be insulin resistant. You can weigh 400 pounds. You still not develop type 2 diabetes because you have beta cells that are like super beta cells that are being protected and working. So you must have both things. So when we teach our medical students now, we say, you have to think of it as two things. Type 2 diabetes has beta cell dysfunction and insulin deficiency, and also insulin resistance. Okay. So this is a trick question, I guess. What factor is important in the eventual development of type 2 diabetes? Insulin deficiency or resistance? What do you think? You were paying attention to both of them, right? So it's both of them, correct? Yeah, so we need to have both of them. So this is just a nice kind of illustration of the natural trajectory. Remember how I said it's a progressive condition to have type 2 diabetes. So let's see what that means. So you start off with 100% super function of your beta cells, right? And so therefore, if you measure your sugar during that time, of course, you have normal glucose. You start to lose a little bit of your beta cell function, and then you start to have what's called impaired glucose tolerance. That's another fancy way to say prediabetes. Okay, so prediabetes is when you are in this yellow zone here, that you're starting to lose some beta cell function, but it's not enough to give you full-on diabetes. It's just enough to, if I put your pancreas on a treadmill and I stress you, you might have a high sugar. But at times of okayness, you're okay. But say this person who is in the yellow zone, they get sick, or if they go to the hospital for some reason, their sugars might be high because of that. But as soon as they're fine and in their kind of homeostasis, normal state, they're okay. They're getting by. But at this time here, intervention is actually a good thing. So if you were to intervene, if somebody is in this yellow zone and you start to tell them, okay, why don't you watch your diet and exercise and try to watch your weight or lose some weight, even if it's a modest amount of weight loss, you can actually reverse. We don't call it cure diabetes. You never cure diabetes when it comes to type 2, but you can put it in somewhat remission. There's actually books on the market called Curing Diabetes or Curing Obesity. And they talk about how if you were to lose, say, if you're in the yellow zone and you lose like 20 pounds or 50 pounds, you can actually reverse your sugars and they look like you don't have diabetes. But the trick is diabetes never goes away. It will come back as soon as you gain that weight back. So you got to be careful. So in the yellow range, you have some capacity to have impact for patients. So that's why primary prevention and family doctors, when they talk to you about this and about losing weight, if your sugar is just hovering, that's a good thing. That is very important because you have a chance to reverse this for a while. In fact, when people are in this range here, they did studies to compare taking metformin versus diet changes. And they found that diet and exercise was at least 30% better at reversing these sugars and giving you better sugars than metformin. So again, for people who are tending to just take medicine, actually lifestyle is better. And then you come into the red zone. So the red zone is when your sugars are really high. So now there's no doubt about it. So now you've lost probably a good 50% of your beta cell function. Plus you have that insulin resistance in the background. That's not helping. And at that stage, this one here, again, depending on where you are, you might be able to do diet and lifestyle alone, but diet and lifestyle will always be there, but you might now need some medication help as well. So if we had to kind of outline, what are the defects in type 2 diabetes again, it is insulin resistance. That's what IR is, insulin resistance. So the insulin is just not working well. And then you have beta cell dysfunction or some relative deficiency of insulin, as opposed to the absolute deficiency in type 1 that Dr. Huang was talking about. So this is a relative deficiency plus insulin resistance, making your body just not able to handle things as it should, and therefore your sugars go up. Unfortunately, our Western lifestyle and diet and the way our cities are laid out are just making us more prone to this. They look at people who, migrate or travel and come to Canada and move here, who did not have diabetes, but they develop it here, probably because of putting on weight and because of decreased, a more sedentary lifestyle. And so if we look at all the things, all the inputs that lead to, what is insulin resistance? People always struggle to understand, what is insulin resistance? This is something that makes your body need more insulin to achieve the same effect. So what things can affect that? Well, just getting old makes us all more insulin resistant. Sorry about that. It's just like it happens. Other things are inactivity, extra weight, especially this area here. So not all fat is the same. The most evil fat of all is this fat here. The rest of your body might look great to have fat there, but it's not the evil factory like fat, that actually there's little cells that are making cytokines and inflammatory things that are making it hard for the insulin to work. In addition, you can have medications. So, like, for example, if you're taking prednisone for any reason or cortisol-based medications for any reason, right? And then you can have conditions in younger people like polycystic ovarian syndrome that can also lead to insulin resistance and put you at risk for diabetes. So there's many inputs that result in insulin resistance. And then the output from that, if people have insulin resistance, they are more likely to have high blood pressure and high cholesterol, and then in turn, heart disease and strokes and so on. So when a person is diagnosed with type 2 diabetes, when do we start screening for complications of diabetes? Does anybody have any idea? So if you're told by your doctor today, you have type 2 diabetes, we're not talking about type 1, we're talking about type 2. When do you think you need to start screening for the eye problems and the kidney problems and so on? Right away. Exactly. Thank you. So the reason for that is something that we already alluded to, but I will show you it in a picture form. Maybe that will make more sense. So if you look at time 0 here, so this is when your doctor diagnoses you with type 2 diabetes, let's say. We know that for the last 5 to 10 years, you are actually having some beta cell dysfunction, insulin resistance. So people in this category here probably have what we call prediabetes, right? So people can have prediabetes for a decade before they even know about it because they just weren't checked for it. And remember, it can be very asymptomatic, meaning there is no symptoms, as opposed to when you're in the diabetes zone, when you have the T's and the P's that Dr. Huang was talking about, thirsty, peeing lots, losing weight, and so on. You probably have no symptoms when you're in the prediabetes. You don't even know that you have it unless you did the blood test. So the reason this is important is, as if at time 0 you're diagnosed, you probably had some changes for the last 10 years. It is important to do the microvascular and macrovascular complication screens. What does that mean? Microvascular means small vessels. Macrovascular means big vessels. So the small vessels that are affected will be in the eyes, the kidneys, and the nerves. And the big vessels be like your heart and so on. If you look at studies that have looked at people with prediabetes versus diabetes, there's definite increased risk in the prediabetes as well. So even if you have prediabetes, you do have increased risk of having all these complications. So people need to have annual eye exams and so on. So what can we do to prevent type 2 diabetes? Because it is becoming a pandemic or an endemic condition. So what can we do? I'm sure you can guess some of the things that we're going to talk about. So what can we do to prevent it? Yes. Lifestyle changes. Yeah. Exercise. Yeah. Diet. Yeah. Excellent. So all of the things that you said are completely right. And you'll notice here a colorful plate is always good. And when I tell my kids that, they say, okay, Skittles. I'm like, no, not Skittles. Nice try. So eat healthy, stay active, know your risk factors and take action. If you have a family history that is really significant for heart disease, then you probably have a higher risk. Then you need to be even more diligent. Maintaining a healthy weight, so important. Avoiding smoking and limiting alcohol. And then going in for regular checkups, because some people haven't seen the doctor in 10 years. They go in and all of a sudden now they have diabetes when they could have been diagnosed with prediabetes a few years ago and made some lifestyle changes that would have prevented the diabetes from, becoming full-blown diabetes. And then taking, of course, prescribed medications. So why do we make such a big deal about diabetes? Like, why is diabetes so costly for us as individuals, for the caregivers of people living with diabetes, for the healthcare system? Why is it that diabetes is such a complicated thing? Well, there's a lot of things that go wrong when the sugar is high in your blood. Okay. So I broke it down to just remind you of those microvascular, so the small vessel. So those are tiny vessels in your eyes and your kidneys and your nerves that get all sticky because you have too much sugar. So what does that cause? It is the leading cause of blindness. Okay. It is a leading cause of chronic kidney disease and needing to go on dialysis. And it also can result in diabetic foot problems. So that means you can have ulcers and infections. And in fact, a leading cause of amputations that is not related to trauma would be diabetes because of diabetic foot ulcers. So really important to, this is not meant to scare people, but this is meant to educate, because I think our goal as physicians is not to make decisions for people, but to help them make good decisions for themselves. But in order to do that, you have to be informed. You have to know what's at stake. I work at the Peter Lougheed, which is in the northeast of Calgary, and that's the poorest quadrant in Calgary. And there was lots of studies happening, and we have some local data that tell us that if you live in the northeast quadrant of Calgary, you have the highest chance of ending up with an amputee. And why is that? It's because it's the poorest quadrant. People don't have a good amount of health literacy. There's a lot of minor ethnic groups that don't speak good English, that don't maybe have access to care, that can't advocate for themselves. So we know that all of these factors lead to poorer control of sugars if you have diabetes, and then risk of amputation goes up significantly. That's also why in Calgary, vascular surgery is based out of the Peter Lougheed Hospital, by the way, because, we need them to be right there to deal with people who come in with the peripheral vascular disease. Now, if we look at the macrovascular complications, or the big vessels, so we talked about the small vessels. Remember the eye, the kidney, the nerves. Now we'll talk about the big vessels. So that would be strokes, heart disease, and peripheral vascular disease. And those are very, very serious conditions. I mean, heart disease is one of the leading causes of death. And when you have diabetes, you actually are less likely to feel the chest pain. So that classic chest pain that people get, and the heaviness on the chest that they get, you don't feel that when you have diabetes. So you can have unusual ways of presenting with heart disease when you have diabetes. As somebody I loved told me once, diabetes is the gift that never stops giving. And that is true, that it just never ceases to amaze by what things it can damage and what problems it can cause. So I just wanted to show you remind you of the small vessel and the large vessel things that we are trying to prevent by doing all these things of looking after our patients, looking after diet and exercise, and then looking after the medications and the screening. Okay. I cannot talk about diabetes and not talk about the mental health, burden that it poses for people who live with it. We talk about all these physical things, but a lot of times I see my patients who are living with type 2 diabetes. And by the way, I happen to have a ton of respect for people living with diabetes, both type 1 and type 2. But this is a chronic disease. This is a life sentence that doesn't go away. It never leaves. You can never forget about it. You can't even have a bite of food without thinking about your diabetes. So I have a lot of respect for people living with diabetes. And we talk about numbers and A1Cs and medications and all that. But at the end of the day, some people are stuck because of their mental health. And we know that chronic disease in general can cause depression and anxiety and other things. Well, diabetes is right up there. If any chronic condition is going to cause these things, diabetes is going to be one of the leading causes of that. So never underestimate how important it is to to address our mental issues with our patients and how they're doing. How do they perceive the burden of living with diabetes? It's not about what we think is important. It's about what they think is important, because after all, they are the ones living with this condition day in, day out. And that's something that our system, unfortunately, does not help with. Like, I find that's one of my biggest, if any endocrinologist ever stops seeing people with diabetes, it's usually because of that. It's because I just don't know how to help my patients. They have all these mental illness burdens, and I don't know what to do for them. I can't help them. They're stuck, and I'm stuck with them. So that's a major, I think, issue that our system needs to address more holistically. You think of the burden of checking your blood sugar, maybe once a day, maybe 2 times a day, depending on what kind of diabetes you have and what medications you're on. You think about wearing this thing everywhere you go. Even people with type 2 can wear the Libre sensor as well, because people are on insulin and so on. So they definitely want to track their sugars and stuff like that. When we think about all the agents that we use, it is overwhelming for our patients to look at this, but it's our job to simplify things and find the choices that are right for them. I'm not going to go into all the ins and outs of all the treatments, but I want to just point out that we have different targets when we are treating diabetes. So we have some gut targets. Those are those alpha glucosidase inhibitors. So this is when they slow absorption of sugar in the gut. Metformin works more to sensitize your body to insulin. So it works on the level of the liver and the muscle and fat. And then sulfonylureas and glutamides, remember, those are the ones that make your body make more insulin, So they work on the pancreas. And then SGLT2 inhibitors are the ones that work at the kidney to make you pee out more sugar. And of course, incretins are a very unique class. And these are the most recent ones, because they span all of those mechanisms. Okay. So if we look at incretins, and again, this is the Ozempic story, semaglutide. So how do they work? They combine a bunch of mechanisms. So they start in the brain and they suppress appetite. So that's the first thing. That's why people start to lose weight. They also work on the stomach. So in the stomach, they will slow down the motility of the stomach, which means that your stomach will take longer to move that food along. Why is that a good thing? Because if you feel full quickly, you won't eat as much. So it's another way that people lose weight. It makes your stomach sluggish. It makes it like move slowly. Are you still awake? So that also gives people some nausea. So that's one of the side effects of this medicine. It can make people actually quite sick if you titrate it up too quickly. So we need to go slowly with titrating that medicine. So we talked about the brain and suppressing appetite. We talked about the stomach. Next, we talk about the pancreas. So this medication will stimulate insulin production and will inhibit glucagon production. Both of those things will result in a lower sugar, right? Because insulin makes your sugar go down. If you stop glucagon, it will make your sugar also stay lower. But this mechanism is a smart mechanism. You know, you can have a kind of a dumb mechanism and a smart mechanism. It's kind of the Apple way of doing things, I guess, if you will. But the reason I say that is if you think of your sulfonylureas that you give, they just tell your pancreas, make more insulin, no matter what's happening in the world, make more insulin. So the risk of going low is significant. These agents are smart. They will make your body make more insulin contingent on the presence of food in your gut, of sugar in your gut. So it's actually very safe to be on this drug, even if you are fasting. If you're not on insulin or a sulfonylurea, you will not go low with this medicine. Most of the time. There's always going to be exceptions. So we talked about the mechanism in the brain, the mechanism in the stomach. We talked about the secretion of insulin and inhibition of glucagon. And then finally, it also works as a sensitizer. So there's another two mechanisms in the liver and the muscle that looks just like what metformin does, which is sensitize your body to insulin. So if you look at this class, it works centrally in the brain, in the stomach. It is a secretion, it has to do with secretion, and it has to do with sensitization. So the only mechanism it doesn't cover is the kidney one from that specific class of SGLT2 inhibitors. But that's why the big hype is about this. And this class of medication also has some cardiac benefit, especially in people who have known heart disease. So people who are very high risk. This actually is a good drug class to consider for them because it might improve their chances of not having a second heart problem. So it is important to remember that diabetes is very heterogeneous. I've been in practice for about 20 years and I've never seen two people with exactly the same diabetes. It's just not going to happen. As widespread as diabetes is, it's a humbling disease. And that's because there are so many other things that you have to take into account, including culture and lifestyle and physical activity and mental health and stress and how people perceive their disease and so on and how they deal with it, right? So there's so much to think about. And I love to show my students this because I think it's really important to think holistically when we're thinking about diabetes. We can't just say, here's your medicine, go and come back in 3 months for your next A1C. It doesn't work like that. It's about knowing who the person is. So I like to start here. You know, who is the person? Who's the patient as a person? And that's why I like to know first in my first visit, like, who are you? What moves you? What is your in? Like, what are you living for? What are you hoping to achieve? And then you can understand how the disease impacts them because you know who they are as a person. And then you can take that perspective and deal with it as like, okay, so these are your goals. You want to achieve those things, and diabetes is kind of not really fitting with that. How can we make the diabetes fit into your life rather than make you fit in with the diabetes? And then establishing this relationship where you have a therapeutic alliance. Okay. I used to make the mistake. I will tell you this story. I always share this story because I had a patient who fired me. When I was just a few months into practice. I had completed my fellowship and I was all like, let's go. I'm ready to do this. And this young lady in her 20s, she came to see me once and she didn't come back, and she sent me a note afterwards and she said, I'm not coming back to see you. You were just too intense. You didn't really hear what I had to say and things like that. and I was really crushed, so crushed. But I learned something, and I thank her for that. And I'm sorry that I didn't listen, but it's very easy to kind of just spill out and say, okay, this is what you have to do. This is what you have to do. You have to watch your food. You have to, like, she's like, I know that, right? Like, she's had diabetes all of her life. What is my role as a doctor, as your advocate? How can I help you? Sometimes it's simply by just listening. Like every time you see them, there's no big discovery made other than, what do you need from me today? How can I help you? And I think just giving them this control, because people with diabetes feel like they have no control, and giving them that control and saying, how can I help you achieve what you need to achieve? Or what are we going to achieve? And I always make a pact with my patients. If, your next A1C is high, it's okay. I'm not going to be upset with it. It is what it is. Let's see what happened. Let's see how we can make it better. So I think just having that trust and having this relationship with your patients, that you really don't judge them, like just accept and move on and say, okay, I can't change what happened yesterday, but let's see what can we do for tomorrow, right? And it's about finding that common ground. What is the in for that patient? What do they really want to achieve? Finally, I know we're almost out of time, so I'm just going to say a very quick thing about gestational diabetes. So gestational diabetes is diabetes that only happens during pregnancy, and it's typically in the last part of pregnancy when the placenta is making so many hormones that are opposing insulin, that are causing insulin resistance. So pregnancy is kind of like a stress test. It's a glimpse into the future. It is telling you who is at risk to develop type 2 diabetes when they're older. That's basically what gestational diabetes is. So there are many risk factors that kind of increase your risk of having gestational diabetes. If I show you this list here, I kind of covered the numbers that these factors are important. Which one of those do you think is the most important? If you had to choose, which one of those would be the biggest risk factor for somebody to develop gestational diabetes? What would you guess? Pregnancy? Over 35? Is that what you said, sorry? Yeah. Okay. Diabetes history in the family? Yeah. So let me show you the numbers. So this is just the numbers that the bigger this number, the more correlation that this risk factor is important. So if you look at the highest number in this, it's being overweight. So going into a pregnancy with a high BMI or a high weight increases the risk significantly for gestational diabetes. But there are other things, including the family history as well, like somebody said. Another one that's not in that list is ethnicity. So anybody who's not Caucasian is at risk to develop gestational diabetes more so than somebody who's Caucasian, unless, of course, that Caucasian person is very overweight. Okay. And the reason I mention that is because the highest risk for gestational diabetes in ethnic groups is going to be for Indigenous people. And I love to put the land acknowledgement in context. I don't like to just throw it at the beginning of my presentations. I like to give it context because it is about what do we do with this? How do we actually reconcile? Right? And when I think about this, I think about how pandemic diabetes is in Indigenous populations. And it's not because everybody thinks it's epigenetic. There's probably a little bit of epigenetics, but the bigger thing is about colonization and about the effect that, experiencing racism and discrimination and lack of safety actually has on our biologic being. So it is a fact that biologic transduction pathways are impacted negatively when people are exposed to things like discrimination and so on. So with Indigenous people having very, very, very high levels of diabetes, this is not just because of their genetics. This is a function of what has been happening for decades. And this applies to, of course, Indigenous people, but also applies to other populations as well. So if I go back to our gestational diabetes, I just want to point out that having high sugars in pregnancy is actually bad because high sugar is kind of like a toxin for those babies. And this extra glucose that goes to the baby can cause the baby to put on extra weight. And you might think, so what's the big deal? It's just a bigger baby. But it's not just that. It's actually not necessarily a healthier baby. Those babies are less likely to develop other things because they're distracted by those high sugars. So they're more likely to need help breathing. They might need to go to the NICU, to the neonatal intensive care unit. They might need to be more jaundiced for a longer time because their livers don't develop. So it's a distraction from other healthy functions happening. And there are effects on the baby, of course, and there's effects on the mom, including preeclampsia, which is a dangerous situation where you have high blood pressure in pregnancy that can result in significant problems for mom, including life-threatening problems as well. So not as a small issue. So having obesity and going into a pregnancy with obesity poses a lot of risks for mom and baby. Okay, this is my last slide. I'm going to stop here and I will turn it over to Hannah so that if there's any questions.
Thank you, Dr. Bassyouni. That was a great presentation. We don't have too much time for Q&A, but we'll try and take one question from the audience and I'll pull one from our online audience. So if anyone in the audience has a question, please feel free to raise your hand and someone will give you a mic.
Very good lecture. My question is, does having either type 2 or type 1 diabetes increase your risk of cancer and specifically pancreatic cancer?
That is a very good question. We know that insulin resistance increases risk of cancer. So that is a well-established relationship. So insulin resistance does. I think your question is alluding more to pancreatic cancer as like with Ozempic use maybe, or maybe not. I'm not sure, but not that we know of. So when people just have diabetes, I don't think there's an increased risk of pancreatic cancer just from that. Ozempic has been linked in animal studies at very high doses to pancreatic cancer. So if I have a patient with a first degree relative with pancreatic cancer, I'd probably tell them, think twice about using incretin therapy. If people are overweight, there is an increased risk of endometrial cancer because of the fat in the body converting, making a lot of estrogen, and unopposed estrogen is a risk factor. So on so many levels, being overweight increases risk of cancer, insulin resistance increases risk of cancer. That happens to be a part of type 2 diabetes. As far as I know, type 1, there is no increased risk of cancer that I know of. Is that right, Phil? Yeah. So, does that answer your question? Yeah.
Cool. We have a question from someone online. The question is, how long does the honeymoon phase last in type 1 diabetes?
So typically type 1 diabetes, what we call the honeymoon phase is when you're still making some insulin. It lasts about 6 months. But I have seen kids who last as long as 2 years or longer. And in fact, I didn't discuss my research, but one of the projects we're doing right now is if you change your microbiome, there's evidence that they actually affect how your autoimmune process. So we're actually studying whether change of microbiome can prolong the honeymoon phase of the diabetes.
I also have a patient with type 1 who enrolled in a study in UBC and took something like rituximab, so a biologic agent, a monoclonal antibody that is like an immune suppressant, and he's been in a honeymoon now for about 3 years. But of course, nobody can afford that on a day-to-day basis because it costs a lot of money, like a few $1,000s for each treatment every 3 months. Whereas those agents are used for things like psoriasis and IBD, and they're covered for these conditions, but not for type 1 diabetes to prolong that honeymoon. I think there's a question in the front here.
Oh, thank you very much. I've really tremendously enjoyed the presentation. Sorry about that. Closer. Okay, I thought I was supposed to hold it farther away. Now, I was wondering if you've seen any changes over time in the number of people who have diabetes and have preeclampsia, develop preeclampsia.
Oh, I am the problem, not you. Maybe just turn down the volume a little bit. Mm-hmm. So I would say that, as time goes on, and this is anecdotally, I'm not sure about specific scientific numbers, we're definitely seeing more preeclampsia, but it's probably related to more of the BMI, so the obesity. So yeah, so it's related to weight, because obesity is a strong predictor of risk of pregnancy-induced hypertension. Yeah.
Unfortunately, we're out of time for tonight. But hopefully not to speak too much for our speakers, but I'm sure if any of you have questions, they'd be happy to chat for a few minutes after the session. And for our virtual audience, you can always email me your questions and I'll forward them to the speakers, and our speakers can provide feedback when they're not busy. Otherwise, I just want to thank our presenters for being here tonight. Both their presentations were great. I'd also like to thank the Snyder Institute for Chronic Diseases, Buxa, AstraZeneca, and the Cumming School of Medicine, and each of you, our audience members, for attending tonight's lecture. I hope that you thoroughly enjoyed it and invite you to join us on February 5th for our next lecture on the topic of the effect of climate change on public health, ecosystem health, wildlife, and food security in the Arctic. Thanks for joining us and have a great evening.